Okay, we're waiting. Well, let's just go on to basic life support versus advanced life support. Who is doing that? Is that you, Chief?
No, not me. That's all under ours. Mr. Antrim was, to my knowledge, scheduled to do what AMR's ambulance service.
Okay, city manager, who is doing number 1 and 2?
Well, I know that Chief had a presentation, and I thought it would cover number 1 and 2.
No, sir, we had scheduled for AMR to bring their presentation first so they could listen. So we can watch. We're just going through some technical stuff.
So what is the presentation that you sent me earlier today?
That's our PowerPoint. I was under the impression AMR was presenting first.
They are. Oh, well, they can present first. It's not a big deal.
I just tell you, somebody needs to start presenting or I'm getting off because I got other things to do than sit here for 15 minutes waiting. So let's get it going.
John, can you guys go ahead, please?
Well, Mike, I was sent the wrong links. So sorry, buddy. I didn't mean to hold you guys up.
I understand.
All right, I'll get ready to rock and roll here. Let me know if everybody can see my screen.
Yes.
All right, well, I don't have the ability to stream a camera of myself while I'm presenting at the same time with the way my computer is set up at home, but my name is John Antrim. I'm Regional Director for Global Medical Response, and today I'm just going to kind of do an overview of the ambulance service in Topeka, how we got here today, what our current contract includes, and some statistics from us. Everybody hear me okay?
Yep, we hear you fine, John.
Yes.
Okay, all right. So when I talk about global medical response, sometimes it could get a little confusing. So I thought it was kind of important to just kind of show you the national overlay of our company. Global medical response encompasses 2 legs of our company. One is the AMR Holdco, which is the parent company of AMR, as well as the Air Medical Group Holdings division, which is our flight services throughout the country. In early of last year, they rolled into one, a global medical response, and that's the organization that I work for presently. So this is just kind of a quick overview of what we look like across the nation. I'm not going to spend a lot of time here because what we're really focusing on is the state of Kansas and the city of Topeka. So this is our coverage map for GMR in the state of Kansas. As you can see, we have 8 ground operations, 5 helicopter bases, and 4 rotor wings, as well as 1 industrial fire department in Coffeyville that we service here in the state of Kansas. But today, really what we're going to be focusing on is Topeka and our response within the city of Topeka itself. So to understand EMS and the history, I thought it was a little bit important. Did some digging with the assistance of the ambulance compliance officer, as well as some historians from previous companies, to come up to how in the world did we get to where we are today for providing ambulance service in the city of Topeka. I went back as far as July of 1981. Prior to 1981, the ambulance service was provided by both of the hospitals. Each of them had their own ambulance service that responded to calls. There were some issues with that, so in July of 81, the Ambulance Advisory Board was created. In January of 1982, the city of Topeka rescinded a previous ordinance that they had in place and approved the franchising to allow the county to assume regulation of ambulance services. And this is very similar to the franchising agreement that we operate today under for the city of Topeka. Shortly after they signed Shawnee Ambulance Service into service, they didn't remain in the county very long. They withdrew in April of '93. An ambulance task force was developed to bid out the service. A new RFP was developed. And when I say RFP throughout this process, what I mean is request for proposal. So in July 1983, the RFP was reviewed and Medevac Mid-America was selected to be the contract ambulance service for the city of Topeka. They began their contract December 31st of 1983 with a $450,000 subsidy paid from the county. In 1985, they built their current station at 401 Southwest Jackson, which is where we're currently located at and still currently serving the city out of. And at 91, they added and an additional 7,800 square foot to include a shop and maintenance facility, which we'll talk about here in just a little bit. In June of 1984, Medevac actually sold to AMR. They operated under Medevac until April of 1997, to where they changed the logos on the ambulances to AMR. One of the most interesting things that I found is since Medevac and AMR, there have been no contractual compliance violations in over 37 years during our time of serving the community. In one of the previous meetings, I can't remember, one of the citizens at large asked the question about if the large majority of the runs are happening in the city of Topeka, what type of feedback did we get into the current contract? So I kind of wanted to cover that to answer that question. So when our current contract was up for bid, there was a very diverse and robust committee that was developed. There was representation from the City of Topeka Fire Department. They had 2 members on that board. The ambulance compliance officer. There was rural county representation by the Soldier Township Fire Chief. Both of the hospitals were involved, Stormont Vale and KU St. Francis, as well as a representative from the sheriff's office himself. This group put together what was the perfect solution for Shawnee County and what did they need within the to provide service within the community. So after this RFP was put together, it was then approved by the Ambulance Advisory Board, as well as the Shawnee County Commissioners. It went out for bid, and we were awarded that contract. And that's what we're currently operating under today. So some of the highlights for this contract, that I'm just going to cover some of these, and if you want to read some of them while I'm talking, that's fine. But we are given a limited subsidy of $300,000 that comes from the county. There's no expense from the city for us to provide our service here to the city of Topeka. That $300,000 is used to offset low pay, no pay, or uncompensated care. That $300,000 really just kind of touches the tip of the actual uncompensated care that we see annually. As you can see, I put some numbers from 17, 18, and 19, and kind of hovering in that $3.4, $3.5 million range. A lot of that is driven by the payer mix that's available here in Topeka, whether it's no insured, Medicare, or Medicaid. That's where a lot of this uncompensated care comes from. For our current contract, we entered in January of 2017. It's set to expire December 31st of this year. However, in that contract, we have 5 one-year automatic renewals as long as we remain compliant with our contract. We did begin negotiating through the Ambulance Advisory Board as well as the county just to grant a 5-year extension to the current contract rather than doing it a year at a time. So we're currently in that process. Some of the big highlights, obviously the Unified Joint Medical Director. We pay $40,000 a year to provide the medical director for all of Shawnee County, including the city of Topeka. This was very important in the RFP because what it allowed us to do is to have joint protocols, and those joint protocols made sure that if Topeka Fire arrived on scene or Shawnee Heights Fire Department arrived on scene, we arrived after them, that continuation of care was the same. Because prior to that, that was not the case. So this has been a big benefit. We also provide $10,000 worth of tuition assistance to all Shawnee County fire agencies annually to be divided amongst the 9 fire districts, including the city of Topeka, as well as disposable medical supply exchange. So when these guys use an airway on scene or a bandage or those kind of things, they're allowed to just exchange those items out of our ambulance on scene. There are times that is not able to be done because of national shortage of medications or even difficulties in obtaining supplies. But if that is the case, then there is a process in place that was put in by the Ambulance Advisory Board so that they can get that replacement at a later date. Additional to that, we do provide the oxygen for the first responders. They drop their empty bottles off at our station and pick up filled ones. So that expense is accrued by us as well. So our contract oversight is done by the Shawnee County Ambulance Advisory Board. The Shawnee County Ambulance Advisory Board has representation pretty much from all legs of the stakeholders in our community. So I know I have Kevin Cook as the commissioner that sits on there. As of a couple days ago, that changed to Aaron Mays. So Aaron is now our representative from the county. There's a representative from both hospitals. There's a representative from Topeka Fire, a representative from Rural Fire, and 2 citizens at large. So these are the guys that anytime that there's a change or that there's a problem, or maybe there's a suggestion to how we make our service better, this is where we start. This is where we go. We pitch the idea and then gain their support. And most recently was the addition of the BLS ambulances within our system, which we'll talk about here in just a little bit. I touched on the tuition assistance that we provide for all the first responding agencies. This is just kind of a list of what it looks like and what we've been able to do in the community. As you can see, the rural fire departments have really utilized this and this tuition assistance for them to be able to send people to EMT school to increase their first responder pool. In the early years, 2017, 2018, this was used by Topeka Fire. One was for OSHA-related infection control class, and the second was a mass casualty class for rescue task force, which are like active shooter response type stuff. So this has been very beneficial to the first responder community. Most of them have started with EMTs, but now we're moving into 2020. We're starting to see that they're actually advancing their people, soldier and mission, advanced EMT position. So under our contract, this is our response zones. Each of those response zones has a designated response time. So that designated response zone, as we're talking about City of Topeka, this is where we're really going to focus. So Zone 1 includes the City of Topeka, Mission, parts of Soldier, and Shawnee Heights. So our requirement is, by the current contract, to be on scene within 9 minutes on an emergency call, 14 minutes on a non-emergency call. As you can see to the right, I put some stats from 2018, 2019, and 2020, and you can actually see the targeted average response times that we're hitting. So in 2018 was 5 minutes and 47 seconds. 2020 year to date, we're setting at 5 minutes and 58 seconds. If you're kind of curious what the breakdown of these are, in 2019, 60% of our calls, which is a little bit higher than usual, were emergent, 40% were non-emergent. 2020 is in line with previous years where we're about 50-50. So contractually, we talked about these response times and how do we know if we're in compliance? So our compliance by the contract is we have to be on scene 80% of the time. You can see here, these are broke down into Zone 1, again, encompassing the City of Topeka. 2017, we were on time in 94% of the time. In 2020, up to May of 2020, the data that I have up to this point from the compliance office is we're on scene 93.72% of the time, we're on time. So our goal, even though 80% is all we have to do, we've always really strived to make sure that we're beating or exceeding those responses. Now, in the event that we do not meet those times, there are in our contracts response time penalties. Those response time penalties then go into a special revenue fund that's maintained by Shawnee County. And then the fire agencies are able to utilize these revenue funds to purchase EMS equipment, as well as supplies that they may need to improve their EMS response. So as you look across the board here, you can see we've been able to buy cardiac monitors, automatic external defibrillators. The previous presentation, Topeka Fire talked about their outreach education on Stop the Bleeds. Some of the Stop Bleed kits were purchased utilizing these funds, as well as just a whole plethora of CPR training equipment to make sure that they're able to have the equipment they need. I guess if anybody has any questions, if you just speak up, I could stop, or we can wait till the end, whatever. We talked a little bit about this earlier. So this is 401 Southwest Jackson. I got a picture of the operation in 2015, as well as what it looks like today, 2020. One of the things is the City of Topeka has looked at moving towards and improving downtown revitalization. We also felt it was important to improve the look of our building. So we have repainted it, added new lighted signage, as well as awnings over the doorways and the windows to improve the appearance of the building in that downtown area. This is where we still operate out of. This is where the crews come in the morning or in the afternoon or in the evening, whenever their shifts start. They get their ambulance and they go out into the wide world of Topeka, and we'll explain that here in just a little bit. So our current fleet here in Topeka, we have 9 modular ambulances. When I refer to modular ambulances, I mean the boxes, the bigger boxes. We have 6 transit-style ambulances. That's kind of what's pictured on the right side next to the Soldier Township fire truck. One of our modular ambulances is specialty equipped with a bariatric setup. It does have a ramp and hoist system and an extra large cot for when we transport those morbidly obese patients. We do have 3 support vehicles. Those support vehicles are like the SUVs that are for supervisors who are also paramedics. They do utilize those vehicles to first respond to calls in the event that there's no ambulances available, so they can start and continue in that care. We also have 2 ATVs that were just purchased not last year, early last year, late 2018, I don't remember. But we utilize those for special events such as the parades downtown or any of those big events where we need to be able to access patients through a crowd. They do have full patient transport capabilities on the back of those units. One important thing I think is, within the last 5 years, 10 of these vehicles over here that I'm discussing are all brand new. 3 of them were purchased, 3 mods were received in 2020 at the end of 2020. So I talked a little bit about our shop. We do have a shop, as I alluded to earlier in the presentation. It is staffed by a full-time mechanic. They do have a very rigorous PM, preventive maintenance program. I put a chart up here if you want to take a look at it as I'm talking. It just kind of covers everything that they do and how often they do it. And really the goal of this is to ensure that, number one, these vehicles are safe for our people. Number 2, that they're safe for the patients that we're transporting, as well as they're reliable to make sure that we're getting to the scenes when we're called. In addition to that, because of this PM program, we're able to ensure the longevity of the vehicle, to help keep our operational costs a little bit lower to make sure that we're providing, good service to the community. So what happens when you call 911? And you've probably heard some conversations in the previous meetings where we've talked about ProQA and the EMD process. So when you call 911, a Shawnee County dispatcher is going to answer it. Inside the communication center, we do have 2 employees that are AMR employees that are integrated into their communication center. So when the 911 call comes in, those calls are rolled to our dispatchers. They do the EMD process. The EMD process is a standardized, scientifically validated triage. So I like to explain this to people like when you go to the emergency room. When you first get there, they take you back to the triage room. They do a small assessment. They ask you a bunch of questions, and then one of 2 things happen. Number 1, you become emergent, and you go right back into the emergency department. Or 2, you're non-emergent, and they send you back out into the lobby to wait your turn. And this is kind of the same premise that the EMD process does. So on the right side, you can see a little square that's got A, C, B, D, and E. Those are determinant codes. So based on how the questions are answered, a determinant code is kicked out. And as you can see, an A on the left side is a BLS call. A C, D, and an E on the right side are ALS calls. So this is how we determine whether a BLS unit responds to a call or whether an ALS unit responds to a call. We also determine whether that ALS unit responds emergent or non-emergent based on the information. So this is a process that's been in place for many, many years by the International Association Dispatch Academy, and it's used by many, many organizations, including this is what's newly been integrated into the Shawnee County Communication Center, not only on the medical side, but also on the fire and EMS side to improve the dispatch process. So once that call is received, the dispatchers start entering that information into our Logis CAD system. Our Logis CAD system is very state-of-the-art. As soon as, if you look at the right side, that is an incident registration screen. As soon as a dispatcher starts entering information as an address in there, and that address is then validated through the system, it looks at the map that's on the right side and says, where are my ambulances? Where are they located? What are they doing? What's the closest? What's the most appropriate resource? Once the system has identified that unit, it automatically dispatches them. There's no radio traffic. There's no dispatcher making a decision. It looks at real-time AVL GPS data to determine what's the closest, most appropriate unit. Inside of the truck, every truck has one of these Sonim devices that's located in the center of your screen. It begins to beep, just like a pager would. They can look, they can see their call, they can acknowledge their call, As soon as they click en route, it provides them turn-by-turn GPS directions to the scene. And I think Topeka, maybe they're going to cover this a little bit, but ALS versus BLS, I think that's kind of important for everyone to understand as well. So our BLS units are typically staffed by EMT caregivers. There's usually 2 of them on that unit. EMT's scope of practice is providing basic life support. They can do CPR, they can do simple airway adjuncts, lineage and bandaging, bleeding control, medication administration. Now, this medication list is a little bit longer than what's in our current protocols, and that's only because the Board of EMS just recently changed what they're allowed to do. So with the new scope practices and the protocols are being reviewed by the medical director to increase the amount of medications and the ways that the medications can be administered by the EMTs so that we can implement those into our protocols so that we can utilize those BLS units even more than what we probably are today. On the other side, when you talk about advanced life support, there's at least 1 paramedic on an advanced life support unit, usually partnered with an EMT or an advanced EMT in some cases. And these guys can do everything on the BLS side, plus they can do additional things such as advanced airways, IV access for fluid administration or medication administration. Their medication list is floor to ceiling. Whatever the medical director signs us off on and trains us, we can carry on our units. And another big one is obviously the EKG or the cardiac monitor, having the ability to interpret those rhythms, identify if it's a life-threatening rhythm, provide treatment, and or, maybe it changes the focus of how our treatment is. And we identify that someone's having a massive heart attack by EKG, which is called a STEMI. And then we have systems in place with both of the hospitals. We do a STEMI alert and we transport that patient emergent to the hospital. We don't even stop in the emergency room. We go straight to the cardiac cath lab so they can get those life-saving interventions. So I mentioned earlier, when our crews come on duty, they pull out of the station and they never come back to the station unless, they need to restock or they're having some problems with some equipment. We use a system called System Status Management. And what this does, it allows us to deploy our animals our ambulances based on the number of hours in a day and day of the week. So if you take a look at the map over on the left, you'll see that 2 of those are green. What that means, at the time that I took this SNP from our dispatch system, there were 2 units that were available that were not assigned to a call or transporting a patient or busy at the hospital. So the way the system works is we look at data for the previous 21 weeks from today's date and compare it to last year. And then we determine where's the higher likelihood that calls are going to occur. And then based upon that, we develop a posting plan. So as you look at this map, you can see the 2 green dots. That means we have 2 ambulances that are available. And when we hit 3, then that 3rd ambulance then goes over to the right side of the map down by Central Highland Park at 29th in California. When we hit 4 ambulances, there's then one posted at 17th and Topeka. When we hit 5 ambulances, it goes to 37th and Burlingame. When we hit 6th, they go to 4th in Fairlawn. When we hit 7, they go to 29th and Croco. When we hit 8, then they go out on Highway 24 to Silver Lake to help some of that response up at the Silver Lake and Rossville. So as units are being dispatched, these trucks are constantly moving to make sure that we're setting at those priority posts. One of the questions quite frequently we're asked is, how do we know how many ambulances we need to staff and how do you do that? So one of the things that we're real big on is data. And one of the systems that we utilize is OPAP. What OPAP allows us to do, it allows us to look at call volume and pull real life demands to determine, how many units do we need to have on, what time do we need to have them on, and that's how we develop our schedule. So when you look at this chart down below, it looks a little crazy, a bunch of squiggly lines, but it's really easy to understand. So if you look at the very bottom of the chart, there's times, and those are done in 30-minute increments. With those 30-minute increments, you look up above and you can see the red squiggly line. If this is a patient's heart rhythm, we're in trouble. But that's not what this is. This actually shows us what are the number of active calls that are occurring at that given hour during that 7-day period on Sunday. So I ran this one on January 17th of 2021. And you could see this is the active calls that we've been experiencing historically, call volume on Sundays. The dark purple line up above here is what we actually have scheduled. So this is what our schedule looks like when we're filled. So what we're looking for is we want to make sure that these red lines don't start peaking over this purple and remaining there consistently. So yes, every once in a while, it does peak above that line, just like it will in any system. You know, there's always more fire trucks and ambulances. I don't care what fire system that you go to. So there are times that, you know, it's going to peak outside of our available resources. And that's when that EMD process comes into place to make sure that we're sending the ambulance first to those high priority calls. And the person that's typically waiting in most circumstances are going to be those low level, alpha level calls. Another thing that I'm super proud of, and I know the fire department's talked about moving towards accreditation, and I think that's awesome because accreditation is a good thing. But we also are accredited. We just completed our second reaccreditation process through CAS. What CAS is basically ensures that we're offering the gold standard of in the ambulance industry. So the process is very lengthy, it's very expensive, and it's very time consuming. As the fire department could probably talk about in their accreditation process, you know, not only do we say we walk the walk, but then we have to have independent evaluators come in, and they've come in from all over the United States and spent 3 or 4 days here going through personnel files, going through patient care reports, meeting with the crews, asking them about policies and procedures, and just making sure that not only are we're saying what we're doing, we're actually doing it. So I'm very pleased that our last review last year, we received 0 deficiencies and was awarded a 3-year accreditation. Another thing that we offer to the citizens of the city of Topeka, as well as Shawnee County, is our Life Care membership. The Life Care membership is an annual membership program. And what it does is it allows people to cover their household for a very minimal out-of-pocket expense. I think it's $85. And in the event that you are transported by one of our units, there is no out-of-pocket expenses whatsoever that comes to the patient. So there are several community members that do take part in this program. And in 2021, we really plan to expand this out because as healthcare keeps getting more and more expensive, you know, deductibles keep going up on insurance, max out-of-pockets and copays keep going up. This essentially means that anything that's not covered by insurance is wiped away. Even if they don't have insurance, it's completely wiped away. So it is a real big benefit to members of our community. Finally, I'm getting pretty close to being done. Trying to keep it under the 30 minutes here, but finally, I want to talk a little bit about innovative practices and solutions in the future for AMR Topeka. So we began having some conversations, it's probably been about a month ago, with a bunch of key community stakeholders, some of the fire departments, as well as the healthcare facilities. We began talking about maybe innovative practices that we can bring into the city of Topeka, as well as Shawnee County, to make our system more efficient. One of the things that we talked about was nurse navigation and implementation of nurse navigation into the system. The diagram you see down below is from Washington, D.C. This is where we do nurse navigation. How the nurse navigation line works is very similar to you call 911, you get the 911 operator, they run you through the EMD process. If you hit one of those low-level, alpha-level calls, sore throat, spider bite, stub toe, you know, the things that we see quite frequently, then that call is just rolled right over to a registered nurse in the state of Kansas. That registered nurse then does a triage and then helps that patient. So about 70% of the time, the registered nurse is able to take care of the call without an EMS or fire unit being dispatched to that location. 20% of the time, it's still going to require transport to the hospital. That other time, what it's really going to require is they help them set up an appointment, maybe at an urgent care or with their primary care. If they don't have their own means of transportation, we'll provide it through rideshare services such as Lyft, Uber, or a taxi. So it does a couple of things. Number one, it allows us to keep our units available for the true life-threatening emergencies. Number two, the hospitals are really excited about it because it keeps those patients that don't need to be in the emergency room out of their emergency room so that they can take care of those patients. So again, this is in the very beginning talks for the community, but this is something that we're having some conversations about. By no means are we moving that way yet. The final thing I kind of wanted to talk about is kind of our economic impact on the community. As a for-profit company, we are putting close to almost $4 million worth of salaries and benefits into the local economy here by our staffing and everything. So when you look at those, about 3.2, 3.1 is actually salary. The remainder of that is benefit costs. We do pay franchise fees to the city of Topeka. It kind of fluctuates based on the negotiations that we have with the fire department. Property taxes that we're paying into the community. The sales tax number you see down below here, that is not fully encompassing. This is only major medical purposes or products. And like if we buy a new vehicle or a new monitor, anything that we do locally is not included in that figure when we do trade locally. And then, we do have about anywhere from $16,000 to $20,000 typically worth of volunteer standby for events such as Sunflower State Games or any of these nonprofit organizations that have large events. We typically try to provide them with EMS service at no cost. So as you can see up above, we currently have 97 employees. Several of those employees are associated with Topeka Fire. So they work for us part-time to get additional revenues to help support themselves. So I don't have anything else in my presentation. Does anybody have any specific questions that I can answer?
I'm sure we do. Let me get back over here. I have a few. Let me start. First, can we get a copy of this PowerPoint?
Yeah, I can provide you a copy of that.
Okay, that'd be great because I missed some, and this is what I missed. So on response time for emergencies, it is 7 minutes and 36, or is it 5:51?
So if we go back in the presentation, let me see here, let me get back here. So in 2018, we're setting emergent average response time in zone 1 is 5 minutes and 58 seconds. By contract with the county, we have up to 9 minutes to get there, but we're performing, as I mentioned in the next slide, significantly higher than what we're required to do contractually.
All right, but it's still 6 to 7 minutes, okay? And then you said you have 9 ambulances. How many average number of ambulances are on the street usually?
So when we're fully staffed and everything's running like it's supposed to, our peak deployment should be, I believe it's 8 ALS and 1 BLS unit during peak deployments.
Okay, but okay, so what's the average though of that there's an ambulance just sitting waiting? You see what I mean? Is it an average of 7 of them stay busy and 2 don't? What's the average number that one actually?
Right, so we run our system very efficiently, and kind of what we look for, we want our people about 40% of the time we want them busy or doing something. So we try and run very efficient. To say that, it's very hard. I mean, there are times that and it happens frequently, where there are more calls than ambulances. I mean, I'm just being completely honest and frank with you, and it does that in every system. But just to say how many are setting and what average, it's very difficult to say. We just have to rely on our response times and our compliance within our contract.
Well, then do you have information on how many times you didn't have an ambulance available for a call?
We might be able to pull that. And when you say not available, like not available at all, or maybe there was an extended scene time that the fire department was waiting?
Well, both. I mean, if there's no one available, then what happens?
So if there's no one available, then the first responder vehicle or our supervisor will respond ALS to start stabilizing that patient and or packaging them for transport. If that unit's tied up, then We have very strict policies in place of how long that they're allowed to be at the hospital before we start dropping additional calls on them. And we have things in place to get additional units staffed if we need to. If it's during the week, then we'll staff additional ambulances with office staff if we need to.
Yeah, I'd be interested in knowing how many calls came in and there was no one available. And if you have the data on, like, is 90% of their ambulances usually busy? Is it 50%? If you have that, I'd like that too.
Well, I can tell you, I can provide data as to, I mean, what we call it is unit hour utilization. So I could tell you, I could pull up data today and say that the 6A to 6B truck, and I could tell you that they were busy certain percentage amount of the time of their shift. Is that kind of what you're looking for?
Yeah, but as a total.
Okay, I'll see what I can come up with.
And then there's that Life Care membership. How much is that, and how do people know about that?
So it is located on our website. And like I said, in 2021, the big goal is to do a big push throughout the community to really make sure everybody knows that this is available. There's a couple different options. There's a family plan or there's an individual plan. And I think it's like $65 to $85 annually, somewhere in that range.
Okay, and not to get into that a lot, but then they can call you as many times as they want?
As long as it's an emergency transport, yes.
Okay. Okay. That is all my questions. Anyone, let me get my screen up here. Anyone else?
I have a question, Sandra.
Okay, yes, I can't see everybody. Okay.
John, I know we've talked about a little bit, and just curious how your recruitment's going. You've done some different things recently in order to recruit more paramedics, and we talked about that. And obviously that's key in order for you to run your service. And so just curious what you're seeing and what your trend would be.
So as far as recruitment, we've really stepped up our games. As far as recruitment, one of the most recent things we did starting January of this year, we increased our salary significantly. Our paramedics were making $19.71 an hour to start. They're now been bumped up to $23.16 an hour. And one of the reasons that we've had to do this is there truly is a paramedic shortage across the United States. You can look and see that on you can Google search paramedic shortage, and you'll see that it's happening all over the United States. So what we've really tried to focus on is identify those young EMTs that want a career in EMS and start to grow them. Like currently we're paying for one to go to paramedic school. I got some really exciting, great news today that in January 2, Barton County Community College is going to come back to Topeka and teach a paramedic class within our headquarters like they used to years ago. So that's kind of what we're really focusing on is, can we find local people that we can train that are interested and try and do everything we can to retain them. But outside of that, it's very difficult to get staff.
Thank you.
Okay, Councilwoman Christina Valdivia Alcala.
Thanks, Sandy, Chairwoman. I just wanted to say just a brief amount of information that you gave on the innovative practices. I hope you guys really do a deep dive into that as more information or as the program develops more, because that really sounds like a really good move to have that, possibility of doing a registered nurse and having the kind of walk through instead of having so many emergency calls and, that don't need to go into the emergency, and then walking them through that process to get set up with, with care. That really sounds like a good move, and I hope that y'all stay vested in it.
Thank you. Yeah, it's going to be a big change for the community, you know, and we're very successful in several large communities that we're utilizing this system in. But, you know, it's a big shock and awe, and it's going to be a lot of education and a lot of things that we have to do so that people don't freak out when they learn, when I call 911, I don't get an ambulance every time or a fire truck every time. But yeah, the success of these programs that we've seen has really been great. And I hope we can continue to look at this as an option. Not only does it benefit us, it benefits the hospitals, it'll benefit, you know, wear and tear on fire apparatus, and there's just a whole thing that it can encompass. So I'm excited, and I hope maybe we can continue down that road.
And I think that education obviously is going to be, like you said, a huge component in it. And it sounds to me that if it's done correctly, right, with education and with the sense of compassion and understanding, you know, that it may take a while for it to really sink in. I think it could also help the person that's calling, you know, and thinking that they automatically have to go into ER when they may not have to.
Yeah, and I mean, there's so much things like incorporating Vallejo and the mental health piece of, because currently when there's a mental health crisis, police, fire, and EMS respond. So looking at other avenues of how to get them to the crisis city or whatever, I think there's a lot of benefit that could come out of this for the community for sure. Thank you.
Okay, Councilwoman Ortiz.
Thank you. So my question was, or actually, you used to have a school and a training in your building. So it sounded like you don't have that anymore. Is that correct?
Yeah, so the reason that we stopped that, so it was 2015 when I came to Topeka and I took over as just the ops manager in Topeka. Washburn Tech decided they were going to start their EMS program. So with that EMS program, there was talks of them expanding that to the paramedic program. Well, when they did that, what happened was that shut the door on Barton County due to the Kansas Board of Regents rules. So they had to vacate after their current class. So we've worked with Washburn, we've been working with Barton. And really for us, what we didn't want to do, we didn't want to compete with a local school or a local business that's in education. So we just partnered with them. You know, several of our employees are either adjunct instructors or even primary instructors for the EMT classes, and we sit on their advisory board. But that was kind of the reason that we had to vacate our education program. So super excited that Barton's going to be coming back with a paramedic program because that is something we need in this community.
And I was just wondering, how will you do a big push for that as well? And are there any scholarships available?
So within our organization, we scholarship our employees. You know, there's a certain amount of dollars that we set aside in our budget every year to do that. With the schools, I'm not sure what scholarships or financial aid. I'm sure it is a collegiate program. In order to be a paramedic in the state of Kansas, you have to have your associate's degree. So it is a college credit class and degree class. So I'm sure that, you know, for you know, some of the less fortunate people, there's Pell Grants and those kind of things available.
Do you have back to statistics? Sorry. Do you know how many times, like, have you ever had like 8 or 9 the ALS units on the street at one time? I can't remember what you said about how many are ALS or BLS.
Yeah, so typically when we're fully staffed and nobody's sick and this pandemic has been a little rough on us just like everybody else, it's been more rough on us on work type injuries because of not having the assistance that we've had in the past, responding to the calls with us. But yeah, there's been times we've been fully staffed and had those units on the roads, and then there's been times we've not had that many.
But you know the statistics of it?
No, I don't have that right handy.
I know. Can you get that to us?
Yep, I'll see what I can do.
And do you know, now, I know you're in Shawnee County and what other counties?
So we have 911 service in Shawnee County. We also have 911 service in Wabaunsee County, just to the west of us. We have 911 service in Lynn County, Kansas, as well as Osborne County is where we have 911 services. We have interfacility trucks that do nothing but hospital transport in Kansas City. as well as in Great Bend and Hayes.
But there are 9 ambulances for Shawnee County? Just for Shawnee County?
We do not share our resources with Wabunsee County or any other counties. They're individual business units. They have individual budgets. They have individual deployments for those business units. So we don't share our staff to go work in Kansas City or Lynn County. Now, we may mutual aid into Wabunsee County. And if they have multiple falls or a major accident on the highway, as any organization would when they need assistance. But we don't send Topeka people into Wabunsee to cover calls, if that's what you're asking.
Okay, thank you.
John, this is Brent again. You guys do any transfer services from like Stormont to a hospital in Kansas City with your folks, or do you strictly stick to the 911?
So our priority is our 911 system, and we will not take interfacility trips. And it's been a little bit of heartburn for the hospitals, to be quite honest with you. Our bread and butter is making sure that we're serving the city of Topeka first. You know, if it's a slower day and we have multiple ambulances on the road, we typically don't like to send more than one out of town at a time. But you know, we do this a little bit. It is still a service to the community members because it is maybe a Topeka resident that needs transport to KU for services that aren't available at our local hospitals. But our priority is to focus on the 911 first before we do interfacility.
So does another ambulance service come over and take care of that out of somewhere, or how's that?
Yeah, there is another ambulance service that's up here in Topeka that does interfacility work, Texas EMS. They're primarily here for the VA. They have the VA contract, but they do quite a bit of interfacility work when we're not available. They always call us. If we're not available, then we'll call Tech and roll the call to them.
Okay.
Any other questions, comments? Now flip through everybody here. Okay, thank you very much.
It's clear, Mr. Selden had his hand up.
So I would like
Okay,
to thank you for your presentation. I think it was a clean, pretty well clear presentation. I'm not quite understanding. It seems like a lot of excess information is being wanted, but it seems like you guys are providing a clear service to the city and doing a very good job. I did do a little bit of research on you guys and how you have been accredited, and you're keeping your equipment up to date. And it sounds like a great idea that you're getting your classes back in the house. That is it. Thank you.
All right, thank you, sir. I appreciate it.
okay, thank you for that presentation. Who is up next? City Manager?
Chief, are you ready?
Yes, everything's in order. So Richard Siegel, our Chief of EMS, is going to step up and explain his presentation. If I could have our screen shared as soon as I open this up, I'd appreciate it.
Well, good evening. Can everybody see the screen there okay?
Not yet.
All right, I'll let Chief Duke, it's his computer here, so I'm gonna let him pull it up there. Yeah.
Not yet. We have it up here.
Nope.
Oh, crap. Sorry about that. We are having technical difficulties with this computer. I apologize. I'm gonna have to switch. If you bear with me, I have to switch.
You're all right.
There. Do you see it now?
Nope.
Are you sharing?
I asked to have it shared.
But you have to go down to the bottom and click on share
Yes, I
screen.
did. I did click on it and then I moved over. Hold on.
Yeah, you have to hit the green share screen button from your computer. You have opened up the capability to share, but you have to do that.
All right, man. Just a second. I thought I did. Nice. Here we go.
There you go.
There we go. Sorry about that. Let me get back to the beginning. Let me have to pull this over. All right. Richard.
So I just want to verify, what do you guys see on your screen right now, just so we're in the right, so we can do this well for you?
The EMS crystal ball.
Let me back up a slide or two here. We'll just start with that because I actually have enough of my presentation memorized. I can pull this off here. So we'll start there and then we'll move ahead. And I'll have Chief Duke jump in and those. For those who don't know me, my name is Richard Sigel. I have the privilege and honor of serving as the EMS chief here for Topeka Fire Department. I've been in this role now a little over 4 years, since April of 2017. When the EMS division was handed off to me, I had no budget and not even an office. And so we started off with that way and rolling this forward. As I wanted to put the presentation together for you guys here tonight, one of the things I wanted to put with some disclaimers, and the single biggest one is this is not information to take over the ambulance service for Shawnee County and or Topeka. This is just taking the Topeka Fire view of it and moving forward. So I just wanted to kind of put that out and then obviously roll through about several hours worth of information and present this in a timely manner for you guys, just making your time meaningful and valuable there. So on the slide there that's referencing the EMS crystal ball, John touched on some of this a little bit. I want to expand a little bit further there. One of the things that's going on in EMS that we all have to be aware of right now is this movement from a service to a provider. And what that's doing, this has been evaluated at the national level, Chandler, Arizona being one of the first ones that went in and worked with Medicare to try to reinvent the way of delivering service and funding services along those lines. So you'll hear about this ET3 and the information related to that. We also will talk about the GMT and the Medicaid expansion here in Kansas and what that could potentially mean there. Some other things here is that EMS is evolving to these outcomes focused. In other words, it's not so much about the response time, it's what happened to the patient as this system as a whole. And so with that there, one of the ways that you see that being focused there is this benchmarking. So one of the slides a little bit later, I'll show an example of the paramedic program and some of the updates on that. And just an example where we could set some benchmarks and things related to that side of it there. There's also the shift to this community focus and community focus needs there. And so just as you heard about the nursing line, one of the things that drive and feed into that is you hear programs called community paramedicine or mobile integrated health. There's various versions. It's been discussed here in Topeka for the past several years. I think one of the biggest meetings we had about 30 some stakeholders at the table, but there was just no clear direction, who was going to drive it, where it was going to go, so on and so forth that way. Data, as you guys have asked, data matters. The city invested and the fire department invested in our current patient care report system that now literally I can pull up on my phone if I had to and very quickly get you some of those questions and answers. What's your busiest time of day? And can break that down into very actually meaningful pieces of information. At one of the events there was a lady, Chris Omni, if you guys have heard there, and we're sharing saying, well, I can take your focus that you're wanting to look at this group of people who maybe have high blood pressure and this zip code. We can go, hey, there's 30 people that met that criteria, that we can have that ability to drill that down. And so now that lets us answer some of the questions that I think this commission has been looking for and wanting to get into. EMS 2050 was a national initiative. I participated on some of the surveys with that, and that's what you see on the right there with the picture of some of the things that come out of this. You see this also related to the CPSE document that you received of the 21st century fire service, fire and EMS service there. And that all ties into those new models of delivery. And all this is based off of available technology. If you've heard of the telemedicine where, hey, you can show up on a scene and talk to a doctor, all this is driving this. And that's what's kind of driving this to the future off of that part. So I'm going to try to advance to the next slide. So we'll see what happens here. You run the next slide, Chief. So,
I don't know what to tell you here on this here. Nope. We are definitely having technical difficulties here.
So I'm gonna do this another way here again to keep this going because again your guys' time is valuable here. So you saw the crystal ball. I'm gonna drop down to some quick history in Topeka. And the biggest thing that we need to know is that Topeka Fire Department has been doing EMS in Topeka since 1913. We tracked the calls down, we looked at it there, and we're using a device called the pull motor that came out of the coal mining industry was being used for rescues. We actually have the information that leads where a Topeka Fire Department vehicle wrecked in Perry, Kansas while trying to deliver this device to a pneumonia patient in Jefferson County. In the 1970s, we moved into the Rescue 1 period, where this is when EMS really got cranked up in the early 70s there. And during that time, what happened was that's where we got some of our first paramedics. The history around that, we haven't been able to track down all the pieces to really know that period of time. The most significant one was in 1983. That got us into the fire medic program. And that's traditionally how we've operated all the way up into 2020 when we finally brought on our first ALS engine companies at Engine 7 and Engine 8. On BLS and ALS, just a little bit of scope of practice. John had it in his program, but I'm just going to add to that there. Basically, an EMT goes to college. It's roughly about 12 college hours if they do it through a community college or one of the local programs there. EMTs, again, focus on the CPR, the AED, the medication, some medications, as you saw, and then into the basic trauma. The paramedics are a 2-year degree. And so with that 2-year degree there, they have the full range and can do multiple things directed either through protocol, medical direction, the EKG interpretation, some of the things that you saw along those lines. So that, so talking a little bit on the volume of records. So when we looked at our volume, and this is focused on EMS numbers only here. So on EMS numbers, our big thing there in 2018, we had about 18,646 calls. In 2019, it was little over 19,000. And in 2020, it was 17,619. With that there, what I put on is what I call the COVID dip or the COVID asterisk, because as John would relate, COVID affected everything EMS across the nation there. What you guys do need to know is, on average, the fire department responds to approximately 40 to 60 calls a day. The highest number that we had in that 3-year range is we had 84 requests for EMS responses on the highest day and a low of 27. So that's kind of the basics along that part there. Our current response, we run out of 12 engine companies, 4 truck companies, and 2 aerials. All our truck and aerials are BLS, and then 2 of our engine companies are ALS. And then probably the biggest example would be on car wrecks there is where an engine and a truck and a chief are going to be involved on a car wreck type call. You guys were emailed out the slides there, but basically walking through the anatomy of a 911 call there. The event occurs, the call happens to 911, the dispatch, the response. We have the care, and then ultimately the disposition after that part is what we focus. So we handle most of that part of the call there. Some basic statistics for you is related to our scene times. And so one of the things that when we talk times, I want to explain the 90th percentile. And so 90th percentile, when you're dealing with statistics, and I consider myself a data nerd there, is that when we look at it, how are we performing over that better chunk of time, which is 90% of the time, what does it actually really look like? When you discuss averages can get you in trouble. And the best illustration, a former president said it best there. You can put 1 foot in boiling water and 1 foot in cold water, and that gives you average. So in the fire service, we really focus more on these 90th percentiles. So in 2018, it was 21 minutes and 42 seconds. In 2019, it was 22 minutes and 28 seconds. And in 2020, it was 23 minutes and 6 seconds. The increase that you see into that 2020 was probably COVID related. And so because of that COVID relation there, that's the crews putting on additional PPE and why we see those scene times extended along those parts. The other one I want to talk briefly on response time. So response time is from the time the crews are dispatched to the time that they go on scene. If we're talking resuscitation, we really want that CPR and AED started within those first 4 minutes there, and ALS to be delivered in 8 minutes. And the next piece of information, I'll show that a little bit clearer. Our average in 2018 was 5 minutes and 38 seconds. Our average in 2019 was 5 minutes and 42 seconds. And in 2020, it was 5 minutes and 48 seconds. So that gives us the averages there. What I want to emphasize as well then is that 8 minute mark. 88% of the time in 2018, we were on scene in 8 minutes or less. And in 2020, it was 87%. So Topeka Fire Department has regularly and consistently done that well. The 4 minute mark is difficult to hit, and that's across the nation. Yes, without an abundance of staffing and everything else, that's very hard to hit. So that's a look at the response times and how that part comes in. This is probably the most important one there. This is the slide. If you have those in front of you there, this would be the NFPA 1710-2020 standards. So this is, again, looking at average and 90th percentile. And so in 2018, our average travel time was 3 minutes and 57 seconds. In 2020, it was 4 minutes and 10 seconds. So we're consistent in what we're providing with our current staffing level, meeting those demands. The 90th percentiles then shift, and those move into the 6 minutes and 29 seconds in 2018, with it being 6 minutes and 40 seconds in 2020. So when we're discussing and you guys make that determination as to what do we want to set that travel time to be and looking at that, that's one of the things that you guys really need to take into consideration when we evaluate that part. I believe Ms. Claire was asking some questions on, how long are we waiting for an ambulance? And the correct answer was, prior to last year, no one could give you a definitive answer. I was challenged by Chief to step that up. We found a way to record it in our reporting system. And so what we call it is the wait time. And across 2020, on the calls that we were able to record that time there, our wait time for AMR was about 4 minutes and 58 seconds. Total calls that we found that they triggered this was across 1,278 calls. And out of those there were 471 patients that were code yellow or code red based off of the information that we had. So we now know that number. We're continuing tracking that going forward. So we'll build those statistics out for us and keep looking at a more in-depth look into that. Our paramedic program update. Example of some of the information there is we had a total of 61 IV attempts documented with 42 successes. And this is where I was talking that benchmarking. Maybe we go, we're not happy with that. We want to see that better. So we train, we evaluate, we run the data and see, did we make a change on that? One of the examples that we were effective in doing that was are we getting that stroke assessment on our patient or on stroke patients? So we looked at the data, we compared ourselves to some national benchmarks. We weren't doing what we wanted, so we emphasized it, and we saw a massive shift into that, now we're getting that recorded. And what it means is a couple things. And maybe it wasn't that it was being done. Maybe our guys were just busy taking care of the patient. But through that awareness, and now we have that, and so we can see those improvement systems there. The medications that the paramedics are given, we've got epinephrine, Narcan for the opioid overdoses. Epinephrine was probably used on cardiac arrest. Albuterol, various medicines that they're given that they're able to provide. So we had over 60 occurrences documented of medication given. So our paramedics were using their skills and putting it into function there. A couple of important parts is that our paramedics were on 3,457 calls out of the 16,577 in the time period that they've been across 2020. Engine 7 had a little over 2,000 calls, and Engine 8 was approaching 2,000 calls. The one that we want to note, because it really gets into kind of the heart of the conversation here, is with those paramedics on approved leave, so that was their K days, vacation, sick, whatever it is there were 674 calls that we did not have a paramedic on. And so we didn't go down into, well, what was the status of every single one of those? We have that ability to do that, but that's an example of just due to the leave along those parts there. Engine 7 altogether handled a little over 359 code red, code yellow patients, and Engine 8 had 317. On the beginning slides, if we'd had it there for you, code red are those urgent, or I should say emergent patients. They need to see the doctor today. The code yellows, they have a condition, but they need to be seen soon. And so that's what I focus on, that I've been looking at, because that's where we can have the biggest impact on patient outcomes. Somebody who has a stub toe, a minor injury, we're there, we're going to assess them, we're going to treat them, but it's those code red and code yellow patients where the bigger outcomes lie. The other number for you guys to be aware of, and we pulled it, altogether there is just right at 1,799 code red patients, or code red or code yellow across the city as a whole. So when you take that number where the paramedics were off, that left us about 1,123, or about 62% of the patients that we were not able to deliver ALS to. I brought this information to Chief Duke. He took it to the city manager, and we had that permission to go ahead and expand to an additional company that we're bringing on here in a few weeks. So that'll give us some better look at the data, and we can kind of start teasing this out a little bit. Do our paramedics make a difference? I believe they do. I think the evidence supports that. This gives us some additional information to look at, because we were fishing in a big ocean. And so we're looking at those parts. And so that's why we looked at this. And again, we'll have that information here across 2021 here coming out. When we get into alternative response vehicles, the big question is, why the big red truck? That's what's ultimately asked there. Yeah. And so I've coined this phrase, what I call fire first, but EMS is not second. And I use the example of the car wreck that happened out on with the icy conditions there the other day, where you had this vehicle that basically landed on top of the other. Could have been a very complicated extrication, all these parts related to this. And so we never abandon our fire role, because we're already EMS already. And so it allows us to, if that patient required care, if it was a complicated extrication, we can send our firefighters and paramedics in there with the protective gear. They can start the care. There's just multiple advantages of delivering the EMS from that fire side of it there. EMD and that emergency medical dispatch, or the ProQA, this is going to help us define this even better, of sending those right resources. And so that's what we've been working with dispatch literally over the last 2 weeks, is starting to build out those future response plans and how that looks. Some discussions, considerations for you guys to understand that you guys will be the ones to look at there is, when you talk these alternative response vehicles, one of the big things is some of that information is contractual, and I'm not going to address it any further here, because either the union can speak to that, but I wouldn't be in the place to speak to those contractual issues directly. I think but understanding that that is part of these discussions there. We start considering our ALS and BLS combination of, how do we start looking at that staffing? How do we start looking at overtime? How do we look at additional staffing? A question that you might ask is, well, why didn't we hire back for those 676 times? That was not part of the design in the trial program. It was getting some basic information, because we didn't have some of those no's. So that's one of the reasons with it there. when we consider all this, do we start considering and looking at the revenue producing or enabling systems there? That gets into multi-factors as to whether or not you bring ambulance into it, whether you bring other things along those parts there. And then lastly then is the locations. Well, where do you put them? And do you build this around the basis of, do you just put it where you have room in a station, or do you actually put them where you need them? And so we've tried to address that with our paramedic program. We're putting them where we need them. But as we bring additional vehicles, we've had the station debates. Part of that is all in consideration as we're dealing with this. Other things there, you'd mentioned recruiting and talking about this. The possibility of expanding this to alternative response in some shape, way, or form there is, we believe that can improve our recruiting as well. There are folks, and I've been in this business for 25 plus years, they don't like the fire side, but they really like the EMS. Let's give a place possibly for them to land, and vice versa. There's some that I'm not really crazy about this EMS thing, but I really like fire. So we have some ability to do that. And then ultimately how these are deployed, should that be the decision going forward, gets into shift availability. In other words, we may not need it for 24 hours a day. We can go in and look at our peak demands as well. So we know that 8 to 5 is a peak time during the week. We can staff and work around that one, and some combinations related to it there. So our proposed options that we put forth for you guys is essentially this. We can continue doing status quo. I think the desire is to make some change, and that's why we're all sitting here to work on that one. We could go in, and I said this is not a bid to take over the ambulance service, and I'll stand by my words on that one, but we could go in and look at this all in taking over the city EMS. That's not in play. There's simply not that structure to do that right now, and it'd be my firm recommendation that that not be considered at this time. So what we put forth in is considering some proposed examples, and those proposed examples would be some combination of, at a minimum, one ambulance and then some type of alternative response vehicles. And as Chief and I were discussing this, and as we've discussed it as staff, the goal is to fill the gap. You heard some of the percentages there. You heard some of the things along those lines there. I know Jason and Eric can speak to it. I can speak to it from the streets, and every single one of us in there. It's documented. The longest we've waited for an ambulance on scene is 1 hour and 42 minutes. It's out. And so that's one of the long ones, obviously, but there's a lot that fill the middle there. I can get those details. It was not part of this presentation tonight because of the time constraints and building into it. So our recommendations that the commission really needs to consider is the adoption or establishment or further review of some TFD EMS benchmarks. What would you like us to see? You want to see cardiac survival rates, so on, and we can give you some options and look at those there. An adoption or establishment of the TFD EMS response and travel times based off of the information that we had there. And then maybe an adoption then of some combination of ambulance and alternative response. Again, our goal is to fill that gap so we don't run into those long response times and working along those parts there. At the end of that program there, you've got multiple resources that we linked to there. Chief Duke sent out the documents there of the NFPA 1710. One I would really draw your attention to is the NIST study, the NIST study. That was a scientifically conducted study as to how many people do you need to take care of a cardiac arrest. And so that kind of answers the question that you're asking there, Ms. Clear, of the commission. Well, are 2 people enough, and so on and so forth? And if you take cardiac arrest, 2 people is nowhere near enough. The science has proven that conclusively, that after 1 minute of manual chest compressions, your effectiveness decreases dramatically. It takes staff to do that. When you get into the ultra high performing, if you take Seattle, those guys are running an ambulance, a squad, and an additional chief there. They're adding an immense amount of resources to gear that up. So with that, I apologize for the technical difficulty on the slides there. Again, it's not my computer, but I'll leave it. Chief Duke, he knows what he's doing there. But I hope this gives that quick overview to at least start the discussion. I'll be available for questions. And if there's specific details or stats that you guys want to know or see, I will make those available at my earliest convenience.
Wow, that was really informative. I consider a good presentation when I have no questions, and I'll tell you, I only have like one. That's a long wait time. I would agree. I mean, even 10 minutes, even 15 minutes, I just think that's a long time. Okay, so this is like, what are the odds that all fire would be fighting fires and a call come in for someone needing ALS?
Yeah, as John spoke to in his deal, and we actually had the example today, just listening to radio traffic, there was a fire call going on, and there were some additional EMS calls going on in the system. So the system starts getting stressed. And the thing I want to emphasize, Topeka is unique. And like I said, that 84 high call volume day, Topeka is unique that we're an island. In other words, we're not Kansas City that can just call that neighboring jurisdiction for help. We're 100% dependent on us. John mentioned Teeks being in town and along those lines. It would take that direct call to try to get that mutual. We don't have that leverage here. And so today was a really good example. We had a fire call going, and the units, as those holes start opening up in the city there, we were sending units all the way from southeast Topeka all the way to 10th and Jewel for motor vehicle wreck. The crews did what they're supposed to do. They did what they're awesome. The guys, and I can't give it credit enough, and I forgot to mention it because I think this matters. And this, if I leave here leaving one good thing in your mind here as to how good Topeka Fire is, and yes, I'm partial, so I'll admit that one. We had guys the other day on a cardiac arrest call, had this patient CPR'd, defibrillated with an airway in less than 8 minutes, and the guy is still alive. And,
wow.
and so that's not the first time that's happened. I can speak firsthand. I've been on scene. I've done CPR for over 30 minutes while we've been waiting for a transport. This is prior to John's time, but we've had those situations there. But our guys do a good job. And that's why I emphasize we're always fire, but EMS is never second. When we had some of these rescues of these individuals from the fires there, they start getting that medical care right away. Our guys go in, make the rescue, do this, bring this person out where it's a safe location, and start that care right then and there. We're there. We're vested. And that's why I wanted to leave that. And then, like I was saying, though, because the guys were able to pull off of that call, it worked out. We were able to get that response time there. And that's why you see us in that high 88, 87% of the time. If we had additional ALS throughout the community there, that's what we can deliver and drop that on scene there based off of the directions that you guys want to go. So
how many paramedics do you have now?
So currently, right now, in the altogether for the department, we have 12. 2 of us are in management, myself and Chief Andrews there, and then the rest are deployed to the companies. All of them have opted in except one. And we did that based off of the contractual. Nobody was forced to do it. So everybody came on board. We had 2 more opt in this year. So that's what allows us to bring on the additional companies. So that gives us the 10 in the companies right now today. That's going to be one of the things we're going to have to address in the future and in the short term. How do we manage that as people retire, promote, so on and so forth along those lines there? But we're doing that. We can manage it. There's some ways going forward there, and I think we can be very successful in doing what we need to do.
Did you mention anything about the budget? How much this would cost to implement entire, everything that we need?
I will tell you this: we've been running the numbers, and we have those estimates there. I'm going to leave that to Chief Duke and Manager Trout on that one because they're making the determinations and what you guys propose in the council there. So I'm not going to speak out of turn, and I don't want to put anybody on the hot seat. But we have the numbers internally. I can tell you it's not tens of millions of dollars we can do and present. But ultimately, it's I think what this commission decides. What do you guys want to present, and then ultimately is funded at budget time. We're going to do. Like I said, when I started into this, I went a whole year with no budget. Got a little bit, and I'm stingy when it's other people's money. And so I don't spend where I don't have to and try to be very effective, keeping us staffed up and with the equipment that we need to function well.
Well, thank you. Thank you for all you do. Any other questions? Like I said, I can't see everybody, so just ask away.
Hey, Sandra.
Yes.
Hey, this is John. So yeah, that was probably one of our worst calls ever. I will tell you that since that occurred, it was an ankle injury and a psych patient. But since that has occurred, have changed our procedure. Remember when I talked about the EMD process and ranking those calls? We would allow those alpha level calls to hold for extended amounts of time. We've now changed our procedure to after an alpha level call has held for at least 20 minutes, then it becomes a priority call. So we've identified that those resources are there. I don't think you're probably going to see as many as what you had in the past with our procedural changes, but that was something that did occur. It's not something that we're proud of, but it wasn't a life-threatening emergency, and we've taken the steps necessary to address those and try to make it more effective.
Good deal. Yes, Chris.
This budgetary number you just threw out, is this to please explain what you're looking at doing? You're talking about millions of dollars to put paramedics in all the firehouses and basically do away with AMR?
I think he said it wasn't going to be tens of millions, but go ahead.
Yeah, and so that's the short version. As I said, and I've been very clear about that, there is no intention to take over the ambulance service. That's a contractual obligation. I know John would ring my phone right away. You said what? And we would be having some serious conversations. So I make that very clear. It's not in play right now. As we started the paramedic trial program, and that's the best example, we're learning and adapting without making those major investments. In other words, what's the funds needed in order to do X? And so that's how we've been operating and working along those lines there. And this slow forward progress is where way we want to handle this, because we think it's financially responsible. It's making decisions, and EMS is changing daily. COVID is rewriting the rules of just medicine being provided as a whole. So there is no massive move. And so that's why I say, that's why we're not looking at spending millions of dollars here. It's making those strategic investments to better serve. And the whole goal is to fill that gap and to be there for the citizens when they call and offering them that best service available, whether that be through AMTs, whether that be through paramedics, all the parts there that are subject to negotiations and those things there. That's where the decisions will lie based off of your guys' recommendations, and then the city's negotiating what they're needing there, working with Local 83 on it.
Thank you.
Well, then this is Christina. My question would be then, when Sandy, you were referencing, do you have a budget? And I heard it's not going to be tens of millions. What specifically are budgetary information were you looking for after this presentation that was made? Because I'm confused.
Is that a question for me?
It's a question for whoever wants to answer it. I don't understand what.
I can go into a little bit of it, because when I got here, there was $100,000 that was allocated to start the pilot program of doing ALS. And part of that was used to buy defibrillators that a paramedic could use differently than a basic EMT, some other types of equipment that allowed them to do that. And then with the contract, we pay our paramedics more. We pay them a stipend each year to be paramedics for us, recognizing their level of service. And then there's some other types of drugs, IV materials that they need. And so I don't know how much it is for each unit to outfit, but it's not a great deal of money in order to be able to do that. And with the money that we had, we've been able to, the 100,000 we haven't even used, I don't think all of that, have we, Rich?
It would have been used at this point. The monitors are in that $40,000 range. And so we used it up, and I think the city manager brought a really good point. In order to start up that additional company there, we had the extra monitors, so we didn't have that additional outlay right up front. And it was literally just the additional wages for those guys to come on board. So I think we've been incredibly responsible with the funds that have been given to us and doing the maximum impact and being able to turn on that third company for literally about $6,000 plus about $1,500 in supplies. That's what we were able to get done to get that additional company online there. And again, that's part of the conversation going forward with future budgets.
And so what you're talking about is currently you have 12 paramedics through TFD.
We have 12 on the department, and there's 10 that are actively serving in the companies.
And what you used to pay them to act as paramedics was that $100,000 as part of the initial pilot program, but that's all been utilized already.
Yeah, and in the packet that I think Chief Duke sent there was a presentation I did to the council in 2019, and it outlined those costs as to what we were able to turn those into paramedic units for the money allocated to that. So that's where those numbers come from there, and then we use those funds, as you said.
Okay, so is the goal then of what we're looking at right now to see how to the continuation of this actually 10 active paramedics with 2 in the background and a continuation of that in the future? Is that what we're talking about with this presentation?
That would be one of the aspects. We didn't get into that. We wanted to give you that deeper view of getting into some of that one. But yeah, that's definitely part of this conversation.
In addition to what else?
So then the ultimate consideration is adding of the additional response vehicles of, do you want to try the SUV response or the alternative response vehicles is how we refer to it. Do you want to look at bringing on an ambulance and trying that basis and filling some of that within the city there? The ambulance, if there's any consideration of revenues and potentially generating revenues, the ambulance is the one that kind of drives those other parts based off of what's available in the system, whether that be private insurance, working with Medicare, Medicaid, other private partners. So along those lines there. So it really gets into, that's what you guys, I believe, are discussing there. And again, if there's anything different than that, but that's my understanding what we're up to at this point.
All right, thank you.
Anyone else?
Yeah, this is David. I have a question.
Yes.
In your strategic plan that was sent out, you mentioned looking at alternative response vehicles in the long range plans. I'm just wondering, I mean, and it says needed budgetary item, I guess. Is that something you guys have already looked at? Do you have recommendations? I wouldn't want to just say, hey, get a motorcycle if really you already know what you want and you have some recommendations.
Sure, and that's why motorcycles, all that, because there are some places that's Austin County EMS in Texas. That's how they respond. Different places there. That's what we're needing back from this commission here, saying, what do you guys want to pursue and send us down there? The needed budget is along those lines there. Currently, the budget process is in its infancy right now, gathering those numbers there. We have the CIP where there's monies available. Those would be part of those decisions between above my pay grade of deciding how those monies would be allocated or spent along those lines. And I think that's part of the direction that this commission is kind of charged and tasked with saying, yeah, we want to do this, this, and this, and then we go to work and we build that program.
Okay.
I just wanted to say one more thing. Since this commission has expanded so vastly and broadly from what it was initially charged to do, and we get such a voluminous amount of information, and we have non-elected people, we have average citizen folks that are participating in this, and we're getting a lot of this information at the last minute. I know it's important that we have these PowerPoints, but I really hope to do the community justice, and due diligence that we have as a responsibility on this commission, is that somewhere along the way, we compact this information instead of all of this all over the place, and then say, this is what this commission is charged with looking at after all of this information that is being presented to us. I mean, this is the first time I have been on a commission, I think that there are other, lay people in this meeting. This is the first time they've been on any kind of this, any type of commission like this. And for us to do the public, the responsibility that we were given, we cannot just have information coming from 500 different places, oftentimes given to us right as we're bumping up against meeting time, without having more, as we get to the decision making that ultimately we're going to need to make for a recommendation to council, that we're just not all over the place and have something more concise. I understand that these presentations are important. I'm just saying that I hope that a lot of us don't get lost in all of being first timers on something like this and trying to go through all of this information without more guidance from the city manager and staff is exactly what we are going to have to look at, and transparency, so that in these meetings, the public can see it as well. Because I can't imagine how confused the public is on this. I know we are the commission, but I'm just saying.
Well, I think what can guide you now are the questions that I sent out. That are the 4 questions right now for us to answer. And, if we need to share how we got our answers to the public, I guess that's fine. But right now, am I right, city manager, these 4 questions?
I saw the questions.
Yeah, and that is, and then we'll expand those questions to a couple of more questions when we go into next month's presentations on the location of stations, what kind of expansions we could do, talk about the Wayne study and how that was brought forward as to the option of building a new station on the north side, and really talk about what's been discussed in the past as to options and needs for stations. And we'll have information that relates to what the conditions of the stations are, those types of things. And then ask those kinds of questions that relate to what do we want our geographical distribution of stations to look like, and make sure we understand what the costs are when we look at those stations and that part. And so that's what is on tap for next month, is to begin to understand and the geographical locations and how we handle calls and responses with our different stations.
And looking over the minutes from the last meeting, I do have a question for Chief Duke. I don't know if this is question time about outside of the presentation, but I know it's already 7:45. So is Chief Duke on?
Yep.
Yeah, he is. He's
Chief, my question to you is in the last meeting, we had talked about, I had asked if you have a breakdown of potential hazards in different areas of Topeka, some sort of hazard risk assessment. And you said that you responded that y'all are planning to do a risk assessment for all of Topeka. So my question is, when has this study started yet? And if not, when do you propose that it is actually going to happen?
Need to unmute, Chief.
Okay, sorry. I just got a notification from Fire Marshal Todd Harrison. The end of this month is when we're going to start collecting information. We did get that grant from NFPA that is going, National Fire Protection Association. It's going to help us do that. They're going to take all the information from us and get it back to us, explain to us where we have our basically a SWOT analysis, our strengths, weaknesses, everything in what particular areas, and how we are covering that response in that area with whatever type of threat there is, whether it be, a factory that are producing whatever, the railway lines, whatever. So that is starting at the end of this month. We did get a grant for that.
And how long will it take for the completion of the study?
That's a good question. All right, I've just had indicated to me it would take us approximately 5 to 6 months to do that, because they have to go out to every facility, check what's at that facility, get information from the companies, like the railroads, the manufacturers and everything. So that's how we will do it. It is a planned study. It's nothing that we're just going to go out and guess what's going on. This is something we're getting direction for.
And has there ever been one done in the past?
To my knowledge, not a full study.
That is unfortunate.
Yes.
Thank you.
Mr. Sullivan?
How about has even a partial study been done?
The only thing
have any information compiled as far as that?
The only thing that's been done recently that the county, which does everything, it's every 5 to 10 years, is where they do a study of hazardous materials moving throughout the community, whether it be by rail or road or air or whatever. And I presented that to the council last year. They just finished the study last year and showing what's in our community and what's coming through our community. But I think hopefully, Ms. Councilwoman Valdeva-Acala, you also want to include in it community risks as well, whether it be the older homes or whatever, besides the big stuff. You want it drilled right down into the community itself.
Correct. And that study that was presented last year, is there any way that we could get a copy of that?
Yes, ma'am. I think I actually have it electronically, and I could get it all out to you. And I'd just like to apologize for the information that you did receive with this. This was for your reference. So if you had time to review it all, then you could, after we had this mess up of a PowerPoint, that you could read the information that we attached with this PowerPoint, that you could send us questions. Okay, what does this mean as it pertains to the PowerPoint? That was the reason I gave you reference material, so you,
okay.
Like you said, I could probably count on 2 fingers here, 3 fingers, how many people that are on Zoom right now understand what the fire and EMS service is and what they do on a daily basis. And that's why I was sending all the information out to the others, so they could probably learn a little bit about us by reading.
Thank you, Chief.
Chief, can you turn off your share screen?
Sandra, I have a question.
Please, there you go. Okay, Ms. Ortiz.
Thank you. I just wanted to confirm with Brent that we are taping these, correct? And if we are or aren't, I think it would be good to put it on our website in sequences of the information that's been given out and also the meetings, so that people can go back, like some of our other meetings, and replay them or re-listen to them. Fire is very, very difficult to understand, but it takes a while. It takes a while, and so you're not going to pick up on it right away. And right when you think you have it, it's confusing. So I think it'd be great. So if people have questions or they question what we've already looked at or what we're doing or talking about, that they can pick that information up and read it and watch and listen to the meetings. And also it'd be great to have maybe Aaron or Jason, they're have a page for us that if they have any questions, who they can contact. I think that would be very great. I think for years I've said this over and over. We do not educate enough. We do not educate the public enough. When we start getting into how much it's going to cost to run and how much it's going to cost to continue to have this truck over here and this over here and that, in people's minds, it's going to start spinning. I was one of those people. It takes a lot. It takes a lot. And you got to talk to the guys to really get to understand it. And I think that would be good for people to understand, so that if we have to raise taxes, or they understand how expensive our equipment is, they will get a better understanding. So if they're not being recorded and we don't have a space for that, I think we should make one.
Thank you. Jason or Aaron, do you have anything to add? Hear from you?
I don't have anything to add, Sandra. Happy to answer questions, but I don't have any information to add.
Okay, Jason?
I just want to add, Sandy, if I could just interject and say that, you know, when we discussed the 2016 interim chief study, and, you know, I'm just throwing this out there for the next meeting about, you know, the combination of 1 and 11 into one new station. You know, I mean, we're going to have to do some deep digging into that, because Chris and I, you know, Chris is Chris Sullivan is a longstanding resident of the North Topeka area. And what we have in the way of, you know, industry out there, manufacturing, mixed use, you know, areas, older residential. I just don't have a good feeling about how we're going to go into this. And I don't know, I hope we don't have to duke it out. But, you know, combining into one station is I don't think it is something that is going, to me, at least with the limited amount that I know, but also listening to constituents and businesses, something that would work. So I'm just throwing that out there. Thank you, Sandy.
Okay. Make sure and look at these questions. Make sure and ask any questions that's going to help you answer the questions, because that's what we're tasked with so far. I know next month's going to be a biggie. So it's February 18th, correct?
Yes.
So we'll pick it up then.
Right. And we'll try and make sure we get everything out that we're sending to you at least a week early. And so that you'll have time to look over it. And I'll work on developing the additional questions that I think we need to be thinking about as we listen to the information about the station locations and status of those. So you'll have that to think of as you begin to look over that information.
Okay. Yes. Mr. Mahan. Is that right?
Yes, Mahan. Aaron Mahan, Shawnee County Emergency Management. Just real quick to expand kind of on Chief Duke's plan for that hazard and risk assessment in different areas around town. My office is tasked with what's called Tier 2 reporting, which comes from across Shawnee County area, which is hazardous materials, dangerous materials and items that are stored around Shawnee County, how they're stored, where they're stored, how much is stored, and exactly what it is. That is then entered into a program that can track all of that. And then that is adjusted yearly. Different companies are required by the EPA and other federal government agencies that are required to send in that information. And then we work closely with the fire department, who enters a lot of that information and helps us track that. That goes along with the commodity flow study that Chief Duke mentioned earlier, that was funded by a HMEP, or Hazardous Materials Emergency Preparedness Grant, that we completed. We got the report back on it, and the rest of that grant is in order to complete several tabletop exercises with multi-first responders, fire departments, law enforcement, fire department, and other agencies to determine how best to respond to a lot of those areas that might include a hazardous material or a dangerous situation. So we will be providing a lot of that information to the fire department as they do their threat study, along with the THIRA that I spoke about a couple of meetings ago, the Threat Hazard Identification and Risk Assessment. So there is a lot of information out there that we can pull together into that one database to supply to Craig Duke to complete his study.
And my concern, just very briefly, my concern with, you know, the time it's going to take to get this study done, and how long this commission may last, isn't going to equal up, and we won't have that information in full by the time perhaps that we're going to be charged to come up with recommendations. I don't know that to be true, but that is a concern I have. Thank you.
Okay, we have 1 minute. Anything else? Going. Okay. Appreciate y'all coming and giving your time. We always have a good discussion. I think we have a good group. So February 18th, 6 to 8. And Luann, you'll be sending out information, correct? And thank you for what you do with our commission. All right, everybody be safe. And we'll talk to you later. Bye.
Luann, can you stay on?